Okay, first of all, I want to thank you all for participating in our fourth webinar. It is a privilege to us be able to contribute to knowledge through these webinars. Today, we have young people from different parts of the world who will present their projects and research. We currently have 115 people in this SIG. So if it is your first time in these webinars, I invite you to join this group. I want to remind you that the mission of the Young WFNR is to connect early career professionals in neurorehabilitation and promote research and education in young people. So thank you for participating and let you, Dr. Hitap, please.
Yes. Yeah. Thank you, Maria. A very good evening to all. Today we have one of the senior most neurologist and neuro rehab specialist from India, Professor Nirmal Surya, who has been very kind to spare his time with us. Professor Volker will also be joining us. So Professor Nirmal Surya, we all know, is the regional vice president of the WFNR for the Southeast Asian countries. He is the president of the Indian Federation of Neuro Rehab. He is the president-elect of the Asian Oceanian Society of Neuro Rehab. He is the president of the Indian Stroke Association. He is the past president of the Indian Academy of Neurology. He was the president when the World Congress in Neuro Rehab was organized in 2018. If I read on all his affiliations and his achievements, the webinar will be short. So I'm going to keep it short and I'm going to welcome Dr. Nirmal Surya to just give a few words to the young neuro rehab specialists who are joined us today, and then we can go ahead, sir. Please.
Thank you, Hita, for your kind introduction. I know that you are my mentee, so you are going to talk more and more about your mentor. But leave that side. I think I'm extremely happy to be here. I wish Dr. Volker also is here. If he's not now, he would come at some point of time. The WFNR has taken a real great initiation to bring the young forum. And when Elia was the first started it as a chair, it has really grown in last couple of years. I remember interacting very actively with you all young guy, Maria and Elia, Hitau and others during the Vienna conference. And I think this is bringing a little bit of a glamour to the WFNR because you got energy, you got new ideas, you are traveling, you are fast, you are technically very, very savvy. You know how to use the AI and Chat GPT. So we are looking at you guys to tell us what is happening new, how we can change, how things can be changing in next couple of years or next decade. You would be able to guide us and help us side by side in innovation, research, education, many more front which are part of happening. We also, when we look at us, we have been attending the World Congress Neurology for years and years and years. Many times we are just doing the routine same and same. It is you people who will stimulate us to take the new things and come and try and come hand in hand or run with you in this new technology. So looking at that technology and this particular webinar on virtual reality in neurorehabilitation, it goes very clearly that you all are very keen and eager to have the new technology coming into the neurorehabilitation. I talk about virtual reality, and you know that this is something great and has come up in the last couple of years in a big way. A lot of research has been done. And I'm extremely happy to see two of my, not really student, but two of the gentlemen who have been very active in Indian Federation of Neuro Rehab from India, both Zulfikar, I know he has presented a couple of times in IFNR, and the Subramaniam, and we call him Sandy very lovingly. He has been from India and has presented in IFNR and WCNR. So I feel very privileged that people who have actively involved in IFNR has now been very active in this new research. Virtual reality in India, particularly, I know of that many centers have started. Leave aside the research in big center like Manipal, you will hear from Zulfikar, AIMS, PGI, and other center. But there are many young individuals practicing in the smaller cities and smaller part. They have been using the virtual reality, because I tell you that in India, the goggles which we I know when I say that 3D Google, we talk about Samsung, which is very expensive, but in India you can get a Google as cheap as $30, and therefore it gives an opportunity to do the research even at a smaller place. And I can see that in next World Congress, we'll see many of the papers coming from India on this low cost innovation in virtual reality and neurorehabilitation. I'm very keen to hear you all guys. Kim is here. He has done a lot of work in that. And I also want to hear from all of you to what new things are there. And I'm sure this is going to be exciting. You have been doing great work. You have been doing regular webinar. And I think you need to build up a bridge between the senior neuro rehab specialist and the young. And that will give the best outcome, not only for the neuro rehab society across the world, but also for the society and people suffering from the disability, particularly neurodisability. Thank you very much once again, Hitav and Maria. I think you all are doing great work. All the best.
Thank you, sir.
Thank you.
All right. So without taking more time, we'll be going through our first presentation, which will be on virtual reality in neuro rehab, which will be spoken by Won CEO Kim. He's an MD and PhD. His research area lies in neuro rehabilitation, in stroke, and traumatic brain injury, application of technologies in neuro rehab. He has a major contribution in VAR, that is virtual reality and augmented reality. At present, he is in the Department of Rehabilitation Medicine as an associate professor at Seoul National University in Korea. And he's also the head of Cardio Cerebro Rehabilitation Center at the Regional Cardiovascular Center. I would like to welcome Professor Kim, and we can go ahead with his presentation. Christine, thank you.
Hello, I'm Dr. Won-Suk Kim from Seoul National University, Bundang Hospital, South Korea. And today's talk, my talk title is Clinical Application of Virtual Reality in Neurorehabilitation. So I'll talk about the some of my experience in clinical application of virtual reality, and also want to share the recent evidence related to this virtual reality rehabilitation. And finally, I will talk about the combining some new technologies with neurorehabilitation for better outcomes. These are my conflict of interest related to my talk today. So based on the motor learning theory, the repetitive task-oriented training should be intensive, and during the progress, it should be step by step, and the motivation is very important. So based on this kind of components of motor learning, you can expect maximum functional recovery. If you think about the virtual reality can provide the various tasks, and then it can be intensive with the motivate the patient with some kind of gaming components. So I think virtual reality is ideally is very good for the motor learning in your rehabilitation. So I can list out these some advantages of VR rehabilitation. So it can be immersive. if we use the head-mounted display, can be very immersive, and then it can resemble real-world setting. So if we want to train the patient in the real environment, simulate the real-world environment, it is very effective in limited spaces and limited time. And observation learning is possible if you think about the patient with very severe upper extremity hemiparesis. In that case, the observation of a motor action is very important. Or motor imagery is also important, so we can simulate the patient motion by using the virtual reality, and then the patient can observe their motion, so we can expect some kind of brain activity. And then augmented real-time feedback is possible, so it can be it is very important for the patient motivation. And we can also adjust the physical and cognitive components according to the patient ability to move or follow the instructions. And then some kind the components of virtual reality can be standardized. And then the virtual reality is very useful for telerehabilitation, for the remote care of patients. So the virtual reality itself is very good for some rehabilitation. But if we think about the motor rehabilitation, it is important to follow the patient motion. So we need some sensors to track the patient motion. So recently we have very developed technologies. So there are various kind of tracking methodologies. So we can use some arm exoskeleton, so we can track the patient motion with the IMU sensors or some potentiometer. And then we can also measure torque or force or joint rotation. And there are hand exoskeletons, so we need some more dedicated design, but anyway, the exoskeleton is also useful to assist the patient motion by using some wire system or some motor system, so it's good. And then for the data glove, by using data glove, we can also measure the motion by stretchy sensors or some potentiometer. We can also use some kind of IMU sensors or potentiometers, or you can also embed the EMG sensors also. So it's very important and very useful. And then some kind of joystick or some external controller is also useful in some cases. And the camera system like Kinect, you may know the Kinect sensors. So by using depth sensing camera, you can track the patient skeleton. So it can be used for track the patient motion. So it can be combined with the virtual reality, and then can mimic the routine rehabilitation setting. So it's very useful and important. The virtual reality can be used in the all time points, all components of motor or cognitive rehabilitation. So it can be used for the assessment, and then by using some sensors with virtual reality, the patient data can be stored in a central database, and by using the artificial intelligence, the patient progress can be monitored, and then we can also make some algorithm to provide the patient-tailored rehabilitation system, or by using the serial data, we can also expect to make some algorithm for predicting patient recovery. So we have many ways to use the virtual reality. This is our first trial to simulate the real-world test in virtual reality, and then this is a box and block test, and then we make some system to simulate the box and block test in virtual reality. We test the system in stroke patient, and you can see here the number of boxes moved in virtual reality and real world shows good correlation, but the number of boxes moved in virtual reality is small, less than real world settings. So we conclude that virtual BBT can be used in the clinical setting, but we have some shortage of the system because they don't have this system did not have the some haptic sensory feedback. So due to this lack of sensory feedback, the patient performance is not so good compared to real world settings. So we suggest that we have to use some haptic devices for the better test in virtual reality. And the Fugl-Meyer assessment is a very popular assessment tool in our research for the motor recovery. So I thought that this Fugl-Meyer is based on the patient motion. So the Kinect sensor can track the patient joint motion during the test, and then we can calculate the score by using some algorithm. So we gather data from patient during Fugl-Meyer assessment. So we simultaneously record the patient motion during Fugl-Meyer assessment by Kinect sensor here. So we gathered many patient data, and we used some AI algorithm that was artificial neural network. So as you can see here, there were some good prediction accuracies for Fugl-Meyer assessment items, and then we have the motion data of patient, and we can calculate the patient motion smoothness or degree of jerky motion. So we can predict Fugl-Meyer score, and also we can get the some more patient motion data. So we suggest that we can use Kinect sensor in the real practice for the assessment, and then we can get the more data about the patient's motion smoothness or accuracy or speed, so it can be helpful to track the patient recovery. And then Fugl-Meyer score is in the virtual reality by using Kinect sensor is well correlated with the real Fugl-Meyer score, and then we calculate the jerky score, and then it was well negatively correlated with brainstorm stage of stroke. And then Dr. Beck, think about that this Kinect sensor can also be used for the rehabilitation system. So we collaborated with the Microsoft Research and then Seoul National University, and then we use two Kinect sensors, and then we can track the patient arm motion, and then we can also track their simple hand motion like mask grasp and release. The total 23 patients were randomly allocated to the virtual reality training group and then sham virtual reality training group. So the sham group was in the sham group, the cognitive rehabilitation program was applied to the patient. This was a pilot study, and due to the small sample size, we failed to prove that the real virtual reality training is superior to sham training. The interesting thing was that during the real virtual reality therapy, the patient can move. They move their arm more. So we used the accelerometer in the patient pancreatic arm, so we can measure the arm motion during the therapy. And the control group means the usual therapy group. So during the rehabilitation, the real VI group shows more counts of arm use than sham and control groups, and then total supervision time during the virtual reality is only 4 minutes during 30-minute treatment session. So I think the virtual reality may not be superior to the real world real user rehabilitation, but it can be used additively in the real world setting, because if you have many local system, and then one therapist can monitor the patient therapy by using that kind of a system. So the one therapist can treat many number of patients. So it can be used additively, or can be supplementary to the real world rehabilitation. In the first meta-analysis for virtual reality, it shows that the virtual reality itself was not superior to the user occupational therapy, but the additional use of virtual reality was better than only user rehabilitation. After this meta-analysis, there were some good clinical trials with enough sample size, and in this trial, they used the Nintendo Wii system, and then they showed that the additional use of Nintendo Wii was not superior, but equally as effective at additional conventional therapy in subacute phase after stroke. So this trial also indicates that the virtual reality is not harmful. It can be useful as an additional or adjunctive therapy to the usual rehabilitation therapy. Dr. Kramer in UCLA conducted this important trial. So they made their own telerehab system by using this gaming, some kind of some joystick or some manipulating some devices, and then they applied and they showed that the telerehab is not inferior to the usual rehabilitation in terms of full motor score improvement. So this trial design was not superiority design, so it's a non-inferior design. So it was statistically significant to show that the telerehab was not inferior to the usual rehabilitation. So essentially, there are many meta-analysis and then some more small-sized clinical trials, but I agree with the Lever's conclusion at 2018 at this time. So virtual reality therapy may not be more effective than conventional therapy for upper-limb outcomes. Clinicians who currently have access to VR programs should be reassured that their use as part of a comprehensive rehabilitation program seems reasonable, taking into account the patient goals and abilities and preferences. So in the meta-analysis, some studies use the conventional gaming system like Nintendo Wii or Microsoft Xbox Kinect, and some studies use their own developed rehabilitation system using their own principles or gaming or virtual reality system. So in this systematic review and meta-analysis, they differently analyze the effect of virtual reality. So they divide the studies to the SVR system, so specific VR system, and then conventional customized rehabilitation system. So in their review, the specific virtual reality system shows better outcomes, and in the studies with non-specific virtual reality system shows no significant effect on motor recovery. So the specific therapy system is important. So the specific therapy means that it should be based on our motor learning theory and or some based on the neuroplasticity. Some specific components we can consider when we think about the virtual reality application to the real clinical setting is so MP is master practice is important, and also explicit feedback or implicit feedback, and the increasing difficulty based on the patient performance is very important. And also the task-specific training is important. So there are many components you should consider to make the virtual reality system for motor rehabilitation with this kind of feedback and adjusting difficult level based on patient performance, and then to induce the master practice or the intensive practice is very important. In this very recent meta-analysis, although the boundaries between virtual reality, augmented reality, or mixed reality is not clear, but they include all kind of studies related to this virtual reality. So they include total 45 studies here. And as you can see here, if we combine all studies here, they showed better outcome compared to the control group in terms of Full-Mayer upper extremity motor score improvement. But if they divide the studies according to the acute needs of stroke, as you can see here, the studies conducted in acute or subacute phase, the number of studies is too small, and then you cannot conclude that this kind of virtual reality therapy is superior to the control group, but in the chronic phase, they showed better outcomes. So I think at this time, so still the clinical evidence that the virtual reality is superior to the usual conventional rehabilitation. So my conclusion at this time is the same. So the virtual reality can be helpful to provide additional dose for upper extremity task-specific training. So it is useful, but I don't think that it is superior to the dose-matched usual therapy. But in some clinical setting, if the physical therapist or occupational therapy is the number of therapists is too small, and then just because of the medical resources too restricted. So in that kind of environment, the virtual reality is very helpful. And then in the chronic phase, if the patient needs some continuous rehabilitation, we cannot provide enough dose during the therapy, so the virtual reality can be applied, and then it can be continued with the telerehabilitation. So it's very useful, but anyway, it depends on the patient or therapist or the nation's circumstances for rehabilitation. In the box and block test and open motor function test, they did not show the better outcomes. So for the box and block test improvement or open motor function test, the end effector, the head, should be improved to do some kind of task. The Full-Mayer, if the patient was improved to use their proximal arm, the score is better than before. So virtual reality training cannot practice the hand well with only the virtual reality. So we need some assistance from therapists or some kind of other devices like robotic devices. So I think with the virtual reality, the other technology should be combined. So till now, I told about the application of virtual reality for motor rehabilitation. But if we think of about advantage of virtual reality, especially for immersive virtual reality, so it can be more useful in the non-motor rehabilitation. So if we think about some hemispatial neglect, it's a visual spatial recognition or perception problem. So as you can see here, the patient cannot perceive the left side There are many kinds of types like egocentric or allocentric neglect or peripersonal or intrapersonal neglect. So there are many types of having neglect. So for the assessment and for the rehabilitation, I think virtual reality is very useful. So the more advantage is that the virtual reality can simulate or mimic the real world environment. So even though the patient have mild anticipation neglect by our assessment, the paper and pencil test, but in the real world daily activities, some patients show some problems, so you cannot adequately or precisely assess the patient ability to adapt in a real world setting. And then, as you know, the real world setting, the task or cognitive loading and anxiety is very high. So before discharge or after discharge, we have to we want to assess the patient ability to adapt in the real world environment or recovery. So we can mimic the real world environment like this during the virtual reality, and then we can adequately assess the patient problems. And then I also try to make the assessment system by using immersive virtual reality. Many researchers doing this kind of researches, and then we can assess the visual extinction, or also we can we can make the patient to track their virtual object, and or can know the patient response to that kind of tracking, and then the auditory response is also can be measured. And we can simulate the paper and pencil test in virtual reality, like the cancellation test or line bisection test. And during the ADL training, you can also assess the patient ability to adapt the real world environment. So by using this kind of object differences, we can notice that if the patient have problem like egocentric neglect, the patient may omit the object in their left side, but in the patient with allocentric neglect also, even in the right side, they may not know that the defect of curve is on the left side, like here. So we can differentiate the type of neglect. So this is a preliminary result. So the group 3 is a neglect group, and group 2 is stroke patient, but they did not have neglect, and group 1 is normal subject, and we use the BITC, behavioral inattention test, and the neglect group shows neglect here, and the normal or stroke patient without neglect shows a higher score in BITC here. In the cancellation test, the neglect group shows a higher missing object here, and the virtual reality test, and this pumpkin missing in the neglected group showed no correlation with MMSE, mini mental state examination. We analyze this correlation because usually in neglected group, the patient has also cognitive impairment. So we want to show that this kind of missing here is not directly correlated with cognitive impairment in neglect patient. And then we also measure the eyeball movement by using eye tracker. So as you can see here in the pumpkin castration test, there was a pumpkin here. So this is a normal subject. As you can see here, they also see the old subject in the right and left side here. But in the neglected, in this patient, neglect patient, they only see the object on the right side. So by using the eye tracking, so we can also see whether the patient have difficulty in perceive the left side or right side well. So it can help us to know the patient, if the patient have the problem. So this kind of eyeball tracking is very useful in patients with very severe cognitive impairment, so they cannot participate in the usual paper and pencil test because of cognitive impairment. So by using some simple visual tracking and then using eyeball tracking, so we can see whether the patient can stare the object well, and then we can know that the patient have problem to stare the some object there. So it's useful in that cases. So this is a prism therapy for hemispatial neglect. By wearing the prism glasses, the object is shifted to the right side by wearing prism glasses, and then the patient is adapted to their left side during the training. So this is has some kind of evidence for the neglect therapy, but there are some barriers for using this because the prism is not always available in oral hospital, and then to adjust the prism deviation level, so it should be the prism glass should be changed, and then it's harder to minimize the self-correction because the degree of adaptation should be adjusted by change the prism goggle, and then we need some kind of this blocking agent to blind the hand trajectory. There's no fun there, and the after effects cannot be quantified well by using this kind of traditional system. So we made this virtual prism adaptation therapy. So in this system, the object is not moved, but the hand trajectory is deviated to the right side. So during the training, the real hand is moved to the left side, and the patient perceives that the object should be in the left side. So this is some kind of modified concept of prism adaptation in virtual reality. So during the 10 degree and 20 degree deviation, you can see some kind of behavioral errors, and after the post-prismatic adaptation, so where turning off the prism mode, you can see the post-adaptation deviation. So the behavior adaptation is similar. By using the FNIR system, we can check that, we can notice that the right prefrontal area is activated during prism adaptation and after adaptation. So the dorsal attentional network may be correlated with the effect of virtual prism adaptation therapy. This is virtual mirror therapy. So by using the motion of the opposite hand, the virtual reality mimic the motion of the paralytic side. So we can mimic the conditions for the mirror therapy. So we call it virtual mirror therapy. By using ease analysis, we found that the M1 area, motor cortical area, is suppressed well during the mirror therapy compared to no mirror virtual feedback, and the parietal cortex in the observational area is also activated well during the virtual mirror therapy. The virtual reality therapy is useful as an adjunctive to the conventional rehabilitation, but it has potential or potent advantage when this technology is combined to other technologies such as brain monitoring systems like FNIRS or EEG systems. So during the motor task in the virtual reality, you can measure the brain activity, and then we know that what area is more activated well. So we can monitor the progress of changes in brain activity, and also we can consider stimulating some related areas by using the neuromodulation technologies such as TDCS or the RTMS and some, or also brain-computer interface can be also combined with the virtual reality. So I showed you the virtual mirror therapy. So during virtual mirror therapy, I showed that the M1 area or parietal, regional parietal area is well activated. So by monitoring that activity using easy system, and then the use of pressure level is monitored and can be visually shown in the monitor in the virtual reality, and then the patient can get the feedback about that. So the closed loop, the feedback is possible. So it's just very potent when the virtual reality is combined with other technology. This is the end of my talk. So thank you for your attention, and thanks again for inviting me to this excellent Congress. If you have any questions, so please feel free to contact me with this email. Thank you.
Thank you, Professor Kim, for such a wonderful talk where he spoke about all the parts where we can use virtual reality. The most surprising one was using it along with neuromodulation, because we haven't touched that mainly in government setup in India as of now. But maybe taking some advices from you, we might be incorporating this in the near future.
Yeah.
Thank you, Professor Kim. And
Thank you.
any of the delegates would like to ask any questions, you all can post it in the question and answer section, and Professor Kim would be happy to answer that. I see I have one question. Uh, what are the disadvantages of virtual reality versus actual therapy?
So for me nowadays, I think the problem is that no sensory input. So you can track the motion of the hand or some motion, but we have a limitation of a sensory feedback. But nowadays there are development of haptic devices. So I hope that in the future, the kind of disadvantage can be resolved. So that's the main disadvantage of virtual reality in neurorehabilitation, I think. So, and then, yeah.
Professor Kim, have you been using virtual reality in children with cerebral palsy for any of the projects or something like that? And if yes, what have been the results as such as?
So I don't have any experience for the patient with cerebral palsy. My main clinical practice is for the adult neurorehabilitation, but I have seen some clinical trials to apply the virtual reality in children with cerebral palsy, and then the young children have a good motivation for using virtual reality and gaming component. I think that it will be very useful. I don't have any experience, direct experience for that. Yeah.
Thank you. Thank you. I'll just see if there are any more questions, or else we can go ahead with the next speaker.
Hira, if you don't mind, I'll just like to chime into your previous question. We
Yes,
actually
yes.
published a review paper with one of my colleagues, Marika Demers and Maxime Robert, on use of virtual reality in cerebral palsy. And there's actually some pretty good evidence with some very good motor learning principles. It's actually an open access paper in JMIR, in Journal of Medical Internet Research. It works. I mean, it's the same thing, just like how Professor Kim said, you know, the things are the same. It's just different because your games have to be a lot more lively. You know, with the kids, they've got to be challenging enough. Kids get bored very easily. So the gaming pattern has to be done in a very different manner than what you would do it for the adults. I mean, for the adults, we can, you can have fewer bells and whistles, as we can call it. But here for the kids, it needs to be a lot more encouraging, engaging, making sure they do it and making sure they don't get into a habit of, only doing that and nothing else.
Exactly.
So,
We've
so
been
that's
doing
the
a
other
study
problem we have.
recently. We've been doing a study recently. We're yet collecting data for it. Parents are not really keen on that screen time, and all of those are there. Maybe that could be some other topic for discussion later on. And there's one more question which says, at what age can we start virtual reality? Is there any age criteria which has been found out, or a particularly mental age? Are we seeing at a cognitive level at which we can take the patients? Or, so if you want to take
Um,
this question.
I think it depends on the purpose of application of virtual reality. So it's just for the simple motor learning. I think it's very simple, so it can be applied to very young age. But our proposal to apply it for some kind of cognition, so it depends on the mental or some intellectual age. So it depends on the purpose of a virtual reality application.
I mean,
Thank
the
you.
point
Thank
is with children, you can ask them to press a button, right? So the same thing, you might have to keep the game, like if the mental capacities are not very well developed, then the game might have to be, or if the child is very, very severely impaired, then, like I'm thinking of a cerebral palsy quadriplegic kid who's really spastic, and doing that kind of stuff. So then there might be just something like, pressing a button and coming up with like a hello, hi, something of that sort, or like, a Jack in the Box kind of a game might be more suitable. Whereas if children are less severely impaired, maybe they have athetosis and, maybe they have that kind of issues where the mental capacities are not as affected, then your gaming's got to be different. So the point is, I mean, that's why I like this technology, because it's a platform where you can adaptively change what you want to. So I think you need to have a suite of games available to you where you can change what you want to depending on your needs.
Thank you. Do we have any more questions, or can we go ahead? Okay, there's one more question, sir. Has there been any research in effects of virtual reality versus mirror therapy, and what were the outcomes in stroke patients, sir?
So there are some reports using virtual mirror therapies. The clinical trial nowadays is very small sample size, and then we don't have enough evidence. But you can see the commercialized ones, like using immersive virtual reality or some other non-immersive virtual reality. You can see there's some commercialized products. But I think that it is useful to moderate the brain plasticity for the better motor recovery. And then I told you that it can be merged with some kind of other technology, such as EEG or something like that. They can be used as some kind of BCI technology. So I think it can be promising, but we need more evidence and we need a more clinical trial. So it's my answer.
Thank you. Any more questions? So thank you, Professor Kim. We are greatly obliged to you staying up so late in the night. And I'll see you in Bangkok, sir, for the Asian Ocean Congress on
Yeah,
Neurorehabilitation.
see you in Bangkok. Thank you. Bye
Thank
bye.
you. Thank you. Good night. Good night, sir. Have a nice day. Okay. So moving on, now we've done with our guest speaker. And as the tradition for the young WFNR webinars go, we'll be having three presentations of research which have been done by distinguished members who are present in the panel. So for the first one would be Dr. Zulfikar Ali, who is bachelor's and master's in physiotherapy in neurosciences. He works in the field of neurosurgery, neurology, and allied health sciences. And he has his skills and expertise in neurological disease, adult neurology, brain injury, brain diseases, and clinical neurology. Presently, he is a PhD student at Manipal Academy of Higher Education in India. So I would like to welcome Dr. Zulfikar Ali to present his work.
Thank you, Dr. Hidav, for the introduction. I hope my screen is visible.
Yes, sir.
Yeah. So happy to see you all here.
Sir, can you just please put it on the slideshow?
Yes, yes.
All
Fine,
right,
right?
all right.
So today I'm going to talk about my PhD research entitled Effectiveness of an Intensive Functional Gamified Rehabilitation Program on Improving the Upper Limb Function and Activity in People with Stroke, a randomized clinical trial, that is the ENTERTAIN trial. So the upper limb motor impairment occurs in 50 to 80% of people with an acute stroke, and 40 to 50% of people with chronic stroke, out of which only 5 to 34% recover full complete upper limb function. To improve a person's capacity post-stroke for engaging in regular everyday activities, upper limb rehabilitation is crucial. So there exist several interventions to improve the upper limb function following stroke, based on the principles of motor learning and neuroplasticity. However, the traditional conventional therapies have several shortcomings, such as lack of active participation and monotonous nature of practices. From a patient viewpoint, increased treatment cost and unavailability of rehabilitation specialist, etc. So game-based rehabilitation has been suggested as one of the alternative novel therapeutic approach that delivers intensive training, that allows interaction, provides real-time feedback and cues to the participants to improve the upper limb function following stroke, as Dr. Kim said right now. Apart from that, incorporating gaming elements to the rehabilitation can promote motivation, engagement, active participation, satisfaction, and thereby foster the adherence of participants to the intervention. So this helps participants to achieve a greater number of repetitions that are necessary for neuroplastic changes as well as motor adaptation to take place. Commercial games and gaming devices may be a suitable option as they are extensively available and come at a reasonable cost. However, commercial games are stereotypically designed for healthy individuals and thus may not meet the requirement of patients with neuromusculoskeletal impairments. So to better fulfill the heterogeneous needs of patients and meet specific therapeutic goals, specialized functional game-based programs must be designed. Keeping this in mind, recently, an innovative, interactive arm rehabilitation device called Armable was developed in collaboration with IIT Hyderabad, India. The Armable device consists of a computer monitor, gaming console on a platform, and height-adjustable actuators. The device caters intensive repetitive training from the very initial phase of stroke recovery. Even there is no movement possible, they can use the device because there is an option of bimanual training. The games in the device are developed exclusively for upper limb rehabilitation and are functional means that mimic the activities of daily life. So we conducted a multi-centric randomized clinical trial investigating the effectiveness of game-based rehabilitation using the Armable device. As we all know that to establish the effectiveness of an intervention, it is imperative that we compare novel treatment techniques with a
Sir, I'm just going to stop you 1 minute, sir. Your screen is not being seen, sir.
Okay.
If you can just stop share and start sharing again, sir, please.
Okay, just a minute. Stop share, yeah. Sorry.
No worries.
Yeah, now?
Yeah. So if you could just change your slide,
yeah.
sir.
Now?
Yeah. So you're on this one, right? Yeah.
Yes. Okay. So we conducted a multi-centric randomized clinical trial investigating the effectiveness of a game-based rehabilitation using the Armable device. As we all know that to establish the effectiveness of an intervention, it is imperative that we compare novel treatment techniques with the dose-matched treatment groups, as this is a major determinant of rehabilitation outcome. So we compared it with task-based training, which is superior to usual care for improving the upper limb motor outcomes by providing functional task-based training. Therefore, our objective was to investigate the effectiveness of an intensive functional gamified upper limb rehabilitation program compared to a task-based training in people with acute and subacute stroke on upper limb function and activity, which are the primary outcomes, as well as on upper limb muscle strength, activities of daily function, quality of life, and video game satisfaction, which were the secondary outcomes. So we conducted a multi-center, single-blind, randomized clinical trial at the Department of Physiotherapy of 4 stroke rehabilitation centers across India. The trial was registered with the Clinical Trial Registry of India, and the trial was conducted in accordance with a priorly published protocol. So participants with acute or subacute unilateral stroke between the age of 18 to 80 years of either sex, having some degree of upper limb dysfunction and Montreal Cognitive Assessment score of more than or equal to 26 points and ability to sit with or without support were included, whereas participants with global or receptive aphasia, major medical problems or comorbidities that preclude their participation in the study, participants with complex regional pain syndrome, functional vision or hearing loss that limit their computer use, vestibular disorders were excluded. Coming to the procedure, stroke population in the multiple centers were screened for eligibility criteria. After obtaining the written informed consent, participants were assessed for the demographic characteristics as recommended by the Stroke Recovery Rehabilitation Roundtable Consensus. One of the investigators done the centralized block randomization using computer-generated random number table. The allocation concealment was performed using sequentially numbered opaque sealed envelope, and the outcome assessor was blinded to the group allocation. Following randomization, participants allocated to the experimental group received gamified rehabilitation using the arm-able for 45 to 60 minutes a day, and comparator group received task-based training for 45 to 60 minutes a day. In addition to this, both the groups received conventional therapy that includes facilitated or inhibitory techniques, strength training, balance training, gait training for 45 to 60 minutes a day, and the total intervention was there for 6 days a week for 2 weeks. So what happens to the participants in the experimental group? They received functional games that mimic the activities of daily life. So we developed some of the games which mimic the activities of daily life. For example, delicious dosa, where they have to make a dosa, which is an Indian dish. Apart from that, strike the mosquito. In that, the mosquito will be appearing on the screen and the bat will be controlled by the console, and participant has to touch the mosquito. And apart from that, we have some more games like a cleaning task, champion cleaner, pouring the water, ironing the clothes, etc. Apart from that, we have developed some more handles to play some of the games. For example, we have bilateral handle, unilateral handle, we have mug handle to play the game, pour the water, power handle to play the game, badminton or tennis. In addition, we have some of the fun games, for example, bounce the ball, fresh fruit catcher, or catching the eggs. So the progression was made by the therapist based on the capability of the participants by shifting from bilateral handle to unilateral handle, or adding resistance by tilting the platform so that participants will be able to perform the anti-gravity movements, or adding a theraband or resistant band for increasing the resistance. And we had, for the games, there were 3 levels: easy, medium, and hard. So in this way, we have made the progression. So what happens to the participants in the comparator group? They received task-based training, for like lifting up the upper limb and placing it on the table, pushing the chair and move the chair, or mopping the table, etc. Minimum of 3 activities were trained per day, and each activity was performed for approximately 100 times within 45 to 60 minutes. So once the participants completed the intervention, we did the post-intervention assessment at the end of 2 weeks. Following this, both the groups received functional upper limb rehabilitation program at their home for 30 minutes a day, 6 days a week for another 4 weeks. Then completion of 1 month follow-up assessment at the end of 6th week. So the outcome measures, we have taken Fugel-Meyer assessment to assess the motor function, motricity index to assess the upper limb strength, the game user experience satisfaction scale to assess the satisfaction, at the body structure function domain of ICF, action research arm test, and modified ranking scale at the activity domain, and stroke impact scale to assess the quality of life at the participation domain. There are 3 time points of assessment: at baseline, post-intervention at the end of 2 weeks and 1 month follow-up at the end of 6th week. All the outcome measures have been taken at all 3 time points except GUS, which was taken at the end of 2 weeks only from the participants in the experimental group. So statistical analysis, we did the analysis with RStudio software, and the data skewness was determined using the QQ plots and Altman criteria. A linear mixed effect regression was performed to explore the association between treatment groups and changes in all outcome measures over the 3 time points. The composite score of the GUS was reported with frequency and proportions, and the level of significance was set at less than or equal to 0.05. Coming to the results, a total of 910 participants were screened for the eligibility, out of which 765 were ineligible, and 25 participants were declined to participate. Finally, 120 participants were randomized. 64 participants allocated to the experimental group and 56 participants allocated to the comparator group. Finally, 51 participants completed the 1 month follow-up in the experimental group and 47 completed the 1 month follow-up in the comparator group. So right now we are in the phase of data entry, data analysis. So for today's presentation, we have done a preliminary analysis that shows the results. So demographic characteristics, participants were comparable at the baseline. The mean age of the participants in the experimental group was 60.5 and in the comparator group was 57.9. Majority of the participants were male with an ischemic stroke. At the time of recruitment, the median post-stroke duration was 30 days in the experimental group and 22.5 days in the comparator group. The mean active duration of intervention was 609 minutes in the experimental group and 572 minutes in the comparator group. So the gains in the upper limb function when assessed with the Fugel-Meyer upper extremity showed a significant change at 2 weeks and 6 weeks in the experimental group compared to the task-based training group. Despite the small effect size of 0.38 and 0.43, the changes in the noted in the upper limb function was more than the reported MCID value of 9 for the experimental group. Whereas the gains in the upper limb activity when assessed with ARAD, it didn't show a significant change at the end of 2 weeks and 6 weeks. Apart from that, the other secondary outcomes like the motoricity index, the modified Rankin scale, and the stroke impact scale also did not show a significant change following the game-based rehabilitation compared to the task-based training. So when we assessed the user experience satisfaction with the GUS scale, the participants reported a high level of satisfaction with the rehabilitation program since the composite score was, or mean composite score was 54.2 out of 63, so which shows a high level of satisfaction with the rehabilitation program. And the major contributors for the satisfaction were the usability or playability with the device, game narratives, enjoyment, audio and visual aesthetics. So the improvement noted in the upper limb function can be explained by several reasons, because the device had functional games which designed specifically for upper limb rehabilitation, and the training was intensive and repetitive. The difficulty level of each game were altered to better suit the motor skills of participants, and increased excitement and motivation of participants, which contributes to increased active time in therapy. So participants were more focused on their gaming experience rather than their physical inability. And the device were able to provide augmented visual, acoustic, and sensory feedback, which was available with the ARM-able device. And participants were getting knowledge of performance in terms of rewards, game score, etc., and knowledge of result in terms of the total duration of gameplay or total game score from both the device and therapist. And majority of participants used gross motor skill to grasp and navigate the console, and we had specially designed handles as per the requirement of each game. The game-based rehabilitation was given at the acute or subacute phase of stroke recovery, which would have improved the upper limb function, which is in accordance with the findings of neuroplasticity-induced motor recovery in the early phases of stroke recovery. A short intervention period of 2 weeks might be considered insufficient to elicit significant changes in the upper limb activity, upper limb strength, disability level, and quality of life when compared to an active control group. So the major strengths of our study, we believe that better adherence coupled with the allocated intervention, engagement of an active comparator group, use of valid and reliable outcome measures in all domains of ICF, multi-center nature of the study, which proliferate the generalizability of the study into different setups, especially in low and low middle income countries. The limitations of the study includes our intervention could be considered short, reflecting upon the current actuality of brief hospital stays due to early planned discharge or lack of insurance for some of the patients. A thorough sensory assessment was not done to evaluate the sensory status of the participant, and daily hand use was not assessed. So to conclude, our results showed statistically and clinically significant improvement for upper limb function at 2 weeks and 6 weeks. However, the changes were not statistically significant for upper limb activity, upper limb strength, performance of activities of daily life, and quality of life outcomes. People with stroke reported a high level of satisfaction with the game-based rehabilitation program provided through the Mabel device, incorporating functional games with ecological validity. Thus, from the initial phase of stroke recovery, game-based training with the Mabel device might be utilized to provide intensive repetitive therapy for enhancing the upper limb motor function. And the authors declare no conflict of interest, and the study has been funded by the Society of Indian Physiotherapists and an industry grant provided through Able Health Private Limited. And at this point, I would like to acknowledge my supervisors, Dr. Senthil Kumaran T and Dr. Ashogan Armugam, for their support. Also, the team members or our collaborators, Ms. Amritavani, Dr. Sanjukta, Ms. Vastav Prabhu, Ms. Punita, Dr. Abarna, and Dr. Vastav Prabhu, and Mr. Abdul Shah. And I would like to extend my thanks to Dr. John M. Solomon for giving this opportunity, and Mr. Habib Ali and Sri Hari for their technical support. Thank you.
Thank you, Sulfikar, for such a wonderful presentation, which was crisp and clear. Have you gotten done with your Viva voce, or is it yet pending?
Yes, yet pending.
So I guess this is one of your pre-PhD Vivas that are happening over here.
Yeah, yes.
So there's one question that has arisen for you. Is on what objective data, how it was decided which games to be given to patient? Was the study done with patients with stage to stage or below level in hand control?
The thing is, the games were chosen based on the context or the interest of the patients. Also, we have conducted an assessment also, like the participants, when they enroll into the game-based rehabilitation, we will do a small short assessment using an assessment game. So based on that, also, we will come to know the upper limb functionality, how much they can move there, or on what radius they can move their upper limb. So with that, we have decided the games. And we have included from brainstorm 1 to onwards, 1 to 5. So even though there is no movement possible, the participants can be included in this trial, because we have an option of bimanual training. So with the other hand, they can use, or they can take the assistance from the other hand, and they can perform the movements.
All right. Thank you for that answer, Zulfikar. Any more questions? Okay, Professor Sandeep has some questions. Yes, sir, please.
Sulfi, he said pre-Viva, so I couldn't keep quiet. Okay, question to you.
Yeah.
Body function, body structure, body function, you saw change in FM. No change in ARAT. No change in anything else. Are you surprised?
Maybe the one thing is, like, maybe the intervention can be considered short. So that's what we, that could be the reason there is no change in the ARAT and other outcomes. That could be the one reason that we assume. And even the treating the upper complex, the upper limb is complex. To get the movements, it is a complex nature. So that is also one of the reason why there is no changes. Maybe with a longer intervention and longer follow-up or longer duration of intervention might produce, yes, or definitely will produce changes in the activity outcomes. Yeah,
that's true. But your results also actually agree with what was done. How many days post-stroke did you start that? I'm sorry, I missed it. I know you must have presented that, but how many days post-stroke were the patients when you started them?
The mean post-stroke duration was 30 days.
Okay, so you're like, okay, so that's still fine, because there's some good evidence that goes back to animal models and that goes back to the vectors trial that Dromeric had done back in 2007. Yes. And there's work on animal models by Dale Corbett's group back in the early 2000s. I believe, I forget who the first author was, but they have shown that very early rehabilitation within the first 2 weeks can actually be problematic. So maybe at that point of time, it is still, it's actually a question of what do we want to focus on? Do we want to focus on impairment? We want to focus on activity. And your results are actually supporting what we have also seen, that improvement in impairment does not necessarily reflect improvement in activity and vice versa. So it kind of makes sense, when you go along those lines. And again, it depends on the specificity of what you did. You were not training the hand. The ARAT looks exclusively at hand function. If you had gone for something else that was like Kahai, which was bimanual because you're doing bimanual training, like for like, you must have seen questions. So the point could also be the fact that the choice of the outcome measure, I know the ARAT is, the SRRR recommends the ARAT, and it's one of the best measures out there. But seriously, if you're not training hand, you don't expect to see changes in the hand with what the ARAT does, especially at such an acute stage where maybe the hand does not yet come down. There is still, that debate is a different issue, whether hand recovers first or later, because BB and Lang's work has shown that's not true completely. But there's a little bit of a ting on that. So these could be some more answers for you, when you do your Viva, you can tell folks, these are some more extra points I would like to draw your attention to.
Thank you for your suggestions. Actually, that's what I mentioned in my limitation also. Hand functions we could not measure, like since that we are considering it as a limitation also. So that cannot tell, as you said, that cannot tell, that will improve the function, like the gross motor function, but fine motor will be difficult. Yeah, that is true. Thank you.
All right, there's one more question from the audience. How much average amount of practice the participants done in EG within 45 to 60 minutes in terms of repetitions, please?
So in terms of repetition, we have not assessed. So we have taken the active time, the active time. So that comes around 50 minutes per day. We have not, it's very difficult to count the repetition. So we have not done that. Counts. So we have not assessed with any accelerometry, or no data has been taken or done. So what we have done, we have calculated the active time in therapy. So that was reported. That was 609 minutes in the experimental group, mean average time, and 572 minutes in the comparative group.
Okay. Thank you. Can we go on to the next speaker, please?
Yes, sure. I will just
yes.
Stop sharing my thing. Sorry. Thank you all.
All right. So I'll just share my screen real quick. So our next speaker for today is Dr. Caroline Rajra. She's a doctoral student in the Sensory Motor Control and Rehabilitation Laboratory of the McGill University Center for Interdisciplinary Research in Rehabilitation of Greater Montreal, Canada. Her academic service is in the Brain Reach North Volunteer, the Brain Reach McGill Montreal QC 2023 till date. She's a Scientista mentor at the Scientista McGill Montreal QC from 2022 till date, and IPN Buddy Program Graduate Student Association in Neuroscience at Montreal from 2021 till present. She's a student of Professor Mindy Levin. So I'll ask Caroline to please go ahead and present her study with us. Thank you.
Okay, thank you. I'm just gonna share my screen. Okay, so everyone can see my screen?
Yes.
Okay, so I'll get started. Thank you for the introduction, and thank you for inviting me to speak at this webinar. So my name is Caroline Rajra. I'm a PhD candidate at McGill University. Like what was just said, I'm working with Dr. Mindy Levin at the Sensory Motor Control Lab at the Jewish Rehabilitation Hospital in Montreal. I'm going to be talking about a little bit of my thesis work related to a new approach to motor learning using error augmentation feedback in virtual reality for upper limb recovery in stroke survivors. So this is just a brief outline of what I'm going to talk about. So I'm essentially going over what I've been doing over the last year or so. I'll keep this brief. So I'll start with some background. Like we've been talking about, stroke is the main cause of acquired adult disability, including sensory motor deficits of the upper limb. The probability of regaining a full upper limb function is still low, even with our best rehabilitative efforts. A major upper limb impairment is a decreased range of elbow extension during reaching, which can lead to the use of compensatory movements like excessive trunk movements, shoulder rotation, and movements that are just assisted by the less affected arm that are illustrated below in a figure coming from Teresa Jones in 2017. We define motor recovery as the reappearance of movement patterns that were present before the stroke. So to improve upper limb recovery, we need to focus on retraining lost arm movement patterns. So retraining lost movement patterns depends on motor learning principles. Newell's definition of motor learning is on the slide. Motor learning can be classified as either implicit or explicit. Implicit learning is a form of unconscious learning that involves intrinsic feedback, which is sensory information related to the movement. An example of this is learning how to ride a bike. Explicit learning is a conscious form of learning that involves extrinsic feedback, which is visual, auditory, or contextual information about the movement and its outcomes. An example of this is learning something or training with a coach helping you. For our study, we're focusing on implicit motor learning because it's thought to lead to better automaticity and longer-term retention of a motor skill compared to explicit learning. So error augmentation, or EA, is an approach to studying implicit motor learning that relies on the magnification of motor errors. EA has previously been used in people with stroke to improve endpoint performance. The example that's on the slide is coming from Jim Patton's group from 2006, where they had patients with chronic stroke and hemiparesis come into their lab and train making straight line movements on a horizontal manipulandum with an added force, with an example of the adaptation in the bottom half of the picture. So in this training paradigm, the subjects who trained with the added force ended up making straighter and more precise movements compared to subjects who trained without the force after just one training session. However, how the movement was performed, and otherwise the movement quality or patterns of individual joint movements were not reported. So patients with stroke often have limited ranges of voluntary control of specific joints, like elbow extension, which we've mentioned. One explanation for this is based on the motor control theory called threshold control theory, that states that voluntary movement is generated by the regulation of spatial thresholds of muscle activation, otherwise known as lambda, in specific joint ranges. The tonic stretch reflex threshold, or the TSRT, is a measure of lambda that enables us to study disordered muscle activation patterns due to, for example, stroke. In the figure on the right, we have the joint angle on the x-axis and the muscle torque is on the y-axis. In the healthy nervous system, the central nervous system regulates the TSRT throughout the entire biomechanical range of the joint, shown in blue. And to relax the muscle, the TSRT is set outside of this biomechanical range. However, in people who've had a stroke, TSRT regulation is often impaired so that the TSRT is abnormally present within the biomechanical range, even when the muscle is at rest. So when you passively stretch a muscle and go beyond the TSRT angle, abnormal muscle activity occurs, which is a characteristic of spasticity. Results coming from Sandeep Subramanian, who's speaking right after me. His study in 2018 revealed that when movements are made beyond the TSRT, the abnormal muscle activation interferes with motor learning. Therefore, training that is restricted to the active control zone may reinforce the use of normal muscle activation patterns and improve upper limb recovery. So based on all this background information, we designed a training program to enhance the range of active elbow extension in people who have had a stroke by using error augmentation and restricting the training to the active control zone. So our objective for the study is to compare the effects of training with EA feedback versus without EA feedback on increasing the range of spasticity-free active elbow extension in people with stroke in a short-term training paradigm. So our three hypotheses include EA training will result in a greater range of elbow extension. EA training will result in better retention and transfer of improved reaching, and EA training will result in better retention and transfer of the increased elbow range. So first, I'm going to talk about our training application that we designed. So we created a virtual reality program where the arm position and angles from the subject are collected using an OptiTrack camera system to create an avatar of the subject arm that they're viewing on a large screen in front of them. If EA is enabled for this patient while they're training, a 30-degree elbow flexion error is incorporated into the arm avatar to encourage greater elbow extension during reaching. All subjects, no matter the training group, received feedback about task success and trained with their trunk restrained. And as subjects reached a better task success score, we would increase the difficulty by decreasing the allocated reaching time and target size. Okay, and we also calibrated the horizontal arm workspace prior to each training session based on the location of the elbow flexor TSRT, which was measured prior to the start of the training period, so that training was not affected by excessive muscle coactivation. And the size of the area of the arm workspace was recorded by the VR program each session. These are our inclusion and exclusion criteria. Just for the sake of time, I won't go through everything, but essentially we're including people who've had a first stroke in the last 3 years and that they have some sort of arm movement problem and spasticity, and that they don't have any other issues that would interfere with task performance. So this is the protocol. Subjects trained over 3 days and 1 week. So on the first day, we started with cognitive assessments and a clinical evaluation with the scales and tests that are listed below. Then we set up the OptiTrack with the subject and recorded a pre-test of the test task, which is described on the next slide. Afterwards, we continued with the VR training, which involves 5 blocks of 30 reaching trials. The second day is just training, and then the third day is essentially the first day in reverse, where we start with the training, we do a post-test of the test task, and a clinical evaluation. The only difference is that there's a follow-up test that takes place an hour after the post-test. So we recorded the elbow flexor TSRT before training, like I said, and then again after training to see if it got bigger. And the size of the active control zone is recorded each training session by the VR program. We also collected kinematic data about upper limb joint angles and endpoint performance during the test task that's illustrated on the left. So to calculate the index of performance, we used a trunk-based measure to include precision and trunk movement during the test task. The test task involved reaching to either a cone or a cube target, depending on the patient's hand capability. And they were instructed to do this as quickly and as accurately as possible from a starting position alongside their body while seated. So the next few slides are a snapshot of the data that I have so far. We're in kind of a preliminary stage of analysis. So in total, we have 22 patients who've completed the 3 days of training. However, we've divided them based on upper limb severity. So there's 11 patients in each group. you can probably notice that there's quite a bit of variability on the data. So I will be commenting mostly on just tendencies in the data. So on the first slide, we have the percent change of elbow flexor TSRT before and after training. And then we have workspace area for all of the patients, and then patients with a mild upper limb impairment, and then a moderate to severe upper limb. To increase their active reaching zones each training session, regardless of severity of upper limb impairment. And then we can get into some kinematic data where this slide is showing upper limb and endpoint kinematics for patients who have a mild upper limb impairment. Generally, patients with the mild upper limb impairment tended to improve the smoothness of the reaching movement, regardless of training group, but we didn't really see any other trends and any other outcomes. And then for patients with a moderate to severe upper limb impairment, we saw that both groups improved in smoothness and precision during reaching, but subjects with moderate to severe upper limb impairments who trained with EA tended to improve the precision of their reaching movements more during a functional reaching task, which is illustrated down here by the index of performance. So in summary, we developed a new approach to upper limb training that can be personalized to the patient's specific limitation and voluntary control of elbow extension. Data collection for me is ongoing, and the final results will inform the design of personalized training protocols using this type of enhanced feedback. I would like to acknowledge Dr. Mindy Levin and all of my lab mates at the Sensory Motor Control and Rehabilitation Laboratory for all of their help and guidance, especially to Dr. Mindy Levin for also giving me this opportunity to speak this morning. And I would also like to thank all of the agencies that have supported me financially during my training. And that's it for me. Thank you.
Thank you, Caroline, for that wonderful job, and we would be waiting to see your publication once the data collection is done. I would just want to ask if there are any questions from the delegate side for Caroline. None and all now, and we have Dr. Sandeep with a few questions, please. Yes, sir.
I just have one. I mean, and I know this worked pretty well because it's sort of an extension of what I did in my postdoc. So, Caroline, one question: did you find the TSRT changing actually after a pre and post? Did you guys do a pre-post TSRT?
Yeah, we did a pre-post. There's it's very variable. It's kind of hard to draw a conclusion. The majority of patients are having a little bit of an increase in the TSRT, but this is also after only 3 days of training. So the next phase of this study is a longer term training protocol that lasts for 9 weeks. So we're hoping to see better changes with that.
We'll talk offline. We'll talk offline more about this. There's some things. Yeah, well, we can talk more afterwards. Anyways, just in the interest of time. That's perfect. Thank you. Good job.
All right. Any more questions from anyone? So yeah, that was it. Thank you, Caroline, for being a part of this, and maybe we can catch each other when we are at the World Congress of Neurology, which is happening in May 2024 in Canada, and we hope to see you there.
Yeah.
All right.
There.
Thank you. Sir, just a minute. I'll just introduce you, and then we can have your slide.
Okay. I'll just stop sharing, right? So hold on.
Yeah.
How do I? Okay. Can I pause? Is that okay?
You will have to stop, sir.
Okay, I stopped it. That's fine. Okay.
All right. So our last speaker for today is Dr. Sandeep Subramaniam, who's a PPTS plus a PhD, and he's an assistant professor at the UT Health San Antonio University in the Department of Physical Therapy. He's the associate editor for neurology section of the Archives of Physiotherapy, editorial board member for Brain and Behavior, Frontiers in Movement Disorder, Frontiers in Rehabilitation Intervention. He's a board member and awards committee chair for the International Society for Virtual Rehabilitation. I would like to say that Dr. Sandeep was the first person to just say, yes, I'm interested as soon as we sent out our emails. So thank you for accepting our invitation to present your study at this webinar, sir. The stage is all yours. Thank you.
Thank you so much. I really appreciate the invitation, and it's a nice thing. So, I mean, I want to thank all the three speakers beforehand who have set the stage for what I'm going to talk. It's nice when people have already done a lot of stuff, so I can skip over some of the stuff and, talk basically what is essential. So thank you again. So I also want to highlight that I do have adjunct positions in physician assistant studies and rehabilitation medicine in the university where I am, but I teach a little bit for them. That's why they gave me an adjunct position. Yeah. So, I mean, we know the fact that there is mounting evidence that upper limb recovery extends well beyond the course of usual rehabilitation. I mean, that there are very good studies that have done this for us.
Sir, just a second, sir. Sorry to interrupt. Can you put it on the presenter mode, sir?
Yeah.
Yours is, yeah.
Okay,
if you can just.
I thought I'm going on to slideshow, but
yeah.
How will
so
I
you
have
just
to?
go on the slideshow, sir, up next to the animation point over there. And over there, you can go into, no.
Okay, I need to go back, right? Okay, hold on.
Yeah.
Okay, so I go back.
Go back.
Yeah.
And in the taskbar on top, sir, we have the slideshow there.
Yeah. Okay, hold on. Yeah, 1 second, because I'm having the thing over here. Yeah. Oh, in slideshow, you want me to go to anim? Okay.
Yeah.
And yeah, I'm using presenter view. That's why. So.
Yeah. So you'll have to shut that, sir, I guess.
Oh, I have to shut that. Okay.
Yeah.
Oh, you guys are able to see the other stuff of mine. Okay, yeah, I got it.
Yes. So that just gets confusing for the other people, and there's lack of
okay, fine.
attention.
Sure. Okay, no problem.
All right. So you go on slideshow, sir. Resume slideshow. So we
Okay.
should be able to start, sir.
Yeah, I said that. Are you able to see my slideshow now, or what's happening? Or maybe I need to go back here on this one.
Not yet. Yeah.
It's probably because I have two screens, so you've gone to my other screen. So just give me 1 second.
Yeah.
Because I have put into resume slideshow. Let me do one thing. Let me stop sharing and start sharing again.
Yes. Take your time, sir. Don't worry.
No. I think what's happening is you guys are able to see the wrong screen. So now is it okay? Are you able to see the right screen?
Yeah. Perfect.
Okay, that's perfect. Okay, great.
All right. Thank you.
So we know that upper limb recovery extends well beyond the course of usual rehabilitation. There is mounting evidence now that it extends well into the chronic stages of stroke. I mean, I don't know, but I trained as a student about 20 years ago in India. And at that point of time, we were told 6 months or nothing. And that is just crap. I mean, for lack of a better word, we know that it's not true. Simplest example is you all go to the gym, you lift dumbbells. If we lift a dumbbell 10 times, we get better at it, 5 kilos, but you don't keep training at 5 kilos, you increase the load. So progressively, if we increase the training load for our patients also, recovery patterns are going to improve. 6 months is when we see the maximal recovery, but beyond that, there is nothing to say that recovery does not happen. And this motor recovery, we know, is attributable to adaptive plasticity and motor learning. There's beautiful papers all over there. This is the most recent review I found. There are other papers after this too, but it's true. And rehabilitation interventions for us actually engage motor learning principles via adaptive plasticity mechanisms. So what we are seeing over here, that adaptive plasticity mechanisms are engaged by rehabilitation through the process of motor learning. Now, there's this wonderful paper by Clyman Jones that talks about the 10 principles of plasticity. And we know that there's variability, task specificity, motivation, intensity. But the mostly important that we care about is the feedback that is provided, in what environment this practice is happening, and also cognition. These are factors that we have to consider in addition to these 10 principles. Because oftentimes we forget it is not just motor learning and motor recovery, but it is cognitosensory motor. We don't talk too much about the cognitive aspects, and we are like thinking, okay, cognition is not something I need to do, but our patients we need to consider their cognition. Otherwise, it's going to be very difficult for us to be able to really train them. I know the previous speaker spoke a little bit about cognition, But I was really interested in seeing what happens and how can we use these cognitive factors to tell us. Because maybe is there a problem with cognition that virtual reality does not help some of the patients? Now, with virtual reality, I know people have spoken, so I'm not going to talk a lot about it. It's basically the advantage of virtual reality is we can create individualized training environments, combining all these above mentioned factors, and they can be manipulated and tailored to the needs of the participants. And we can provide them meaningful feedback. I know Dr. Ali just spoke about the fact that we can give them knowledge of results and knowledge of performance feedback, which is very, very important, something that Caroline also touched upon in terms of when she spoke with implicit and explicit learning. But when we think about cognition after stroke, what kind of most common cognitive impairments we see, they are seen in the domains of attention, they are seen in memory, they are seen in executive functioning, which is problem solving and cognitive flexibility, and in visual perception and visual construction. 4 main broad areas where we see cognitive impairments most commonly after stroke. So then what happens? Do people learn in the presence of cognitive impairments? Can they do it? How is motor learning affected by these things? Now, we know that motor learning, I know Caroline mentioned briefly about it a little bit, we can divide it into either motor performance, which is endpoint parameters. How fast did you move? How straight did you move? How smooth were you? Or movement patterns. In other words, the joint ranges of motion. Because if you think about all the assessments that we use as clinicians, okay, so I have a bottle in front of me, and you ask me, can I pick up this bottle? So I can extend my elbow, I can flex my shoulder, and I can pick up this bottle, or I can move my trunk and do the same thing. So if you talk about my performance was perfect because I could still pick up the bottle. But the movement patterns that I'm using in both of these tasks are something completely different. We could even consider the fact that I'm using my trunk as a compensatory or as a trick movement, for lack of a better word, in how we use it. And the learning, there has been previous research, again from Dr. Levin's lab and other labs, that have shown that when we are talking about motor performance outcomes, specifically straightness, smoothness, and error and speed, these outcomes, when feedback is provided in the real world environments, better performance was seen in individuals who had fewer deficits in memory, problem solving, and cognitive flexibility. There's a very good meta-analysis that was done by Aditi Malik, was the first author in 2015. It's an open access paper. If you guys want to learn more, you can learn that. It was in restorative neurology and neurosciences. And also in 2004, Racheli Kizoni and her group in Israel have shown that in a virtual environment, when you provide feedback, you have fewer deficits in attention and better cognitive flexibility is when you can have better motor learning. But however, the question then comes, what about movement pattern outcomes? Do we know what is the influence of post-stroke cognitive deficits on the ability of participants to learn movement pattern outcomes? In other words, does the presence of cognitive impairments influence what kind of movements the patients are using? And guidelines about cognitive abilities are necessary to benefit from the type of feedback to be delivered. In other words, can we say, do we need to give more KR? Do we need to give more KP? Do we need to provide feedback at all? Not provide feedback? Use this technology, not use it? How can we better personalize or individualize this treatment to people, especially for patients with cognitive deficits? Because if we keep on not selecting these people, our sample sizes are going to be very, very small. So the objective of this study was to estimate whether and the extent to which cognitive impairments in people with chronic stroke are associated with the use of feedback to learn and improve upper limb movement patterns and motor performance. So this was actually part of a bigger study, a bigger trial, which we published in 2013. I'm not going through entire things. I'll give you brief highlights. So here we have our inclusion and exclusion criteria. Basically, you needed to have a chronic stroke, which was a single unilateral stroke. You were between 40 to 80 years of age. Beyond 80, we didn't want other deficits like older age and loss of things to come and start affecting. And your arm motor impairment level had to be 3 to 6 on the Chedok-McMaster stroke scale. So Chedok-McMaster stroke scale is a modification of Fugl-Meyer which is a modification of the Brunstrom's stroke things. We excluded anybody with a brainstem or a cerebellar stroke who had any other problems. We were in Montreal when I did this work, so if you couldn't comprehend English or French, maybe a couple of people spoke Hindi or Tamil and I took them in, but other than that, no other languages. And they could not be currently receiving any other therapy because we did not want the confounding effects of any other therapy on what we were doing. And this was our participation schedule. So in the first week, all the patients came to us. We did clinical evaluations, kinematic recording, and neuropsychological evaluation. From the second to the fifth week, they had 3 sessions, which were 1 hour long per week for 4 weeks. In each session, they practiced 72 trials, and we put them into 3 blocks of 24 trials each. And we randomized them to perform movements either in a virtual environment or in a very similarly designed physical environment. I'll just talk about the environments in a couple of slides. After the 4 weeks, they came back to us on week 6, where we did the clinical evaluations and kinematic recording. They went home, tata bye-bye. They came back after 3 months, and again, we did the same clinical evaluation and kinematic recording. This was a double-blind study, so subjects were stratified at baseline by level of severity, which was by Fugel-Meyer score plus or minus 5 points, and age plus or minus 5. And we block randomized them in 2 per trial arm. As I spoke about the neurocognitive assessment, we had a detailed neurocognitive assessment, which lasted a few hours by a neuropsychologist. And these were the domains that were primarily assessed. Attention, we used the Stroop test, especially the interference score that we used. So if you guys don't know the Stroop test, it's like you'll have words coming on the screen in different colors. So you'll have a word in red that says red, or you might have a word in green color that says red. So you have to tell me the color of the word or the word actually, so you can look at the interference. What are people focusing on? Are they focusing on how the word reads? Are they focusing on the color and those kinds of things? Memory, we did a test of verbal memory. So we looked at delayed recall scores on the Ray auditory verbal learning test. So a list of 15 nouns is read, and after some time, you're asked to repeat those names. So we wanted to see, can people retain this information and then come back? Mental planning, we use the Tower of London, so total move score. So this is like the computer games that we play, and the cell phone games that we play, where you have this change of this water sort puzzle and color, how to get back to those colors together. So we have 3 moves and you have to do something else. So how many moves it takes them. Faster you do, fewer moves you do, better it is. And for visual perception and visual construction ability, we had the Ray Austerlitz complex figure. So you have a 3D figure that you have to draw again. You have to redraw the figure, and then they see how good you are in terms of that. It doesn't have to be perfect. It doesn't have to be very artistic, but are you able to see right is right and left is left, stuff of that sort. In terms of our environments, so as you can see, so the environment is something similar to what Caroline showed you in that big screen. Participants were seated in front of this. We had a supermarket scene. We wanted to make it ecologically valid. In other words, it had to be meaningful in real life to the participants. So both of these, so in the physical environment, we had these 6 targets. And in the virtual environment, as you can see over here, we had these 6 objects. And if one particular target location was in an X, Y, and Z space in the physical environment, it was in the same X, Y, and Z space in the virtual environment. We did a very good one-on-one calibration. We wanted the training to be exactly the same. So the calibration was done first in the physical environment. And if you're training in the virtual environment, then it was there. So people were moving exact. We gave them the same feedback conditions. We gave people terminal KR, that is at the end of it, they got a success like a ping sound. So if the thing was they were told to reach for the Coke can, if they went to the can correctly within the time allotted, they got like a ping sound, like an elevator sound, close enough to it, which meant success. If they failed, we gave them kind of a kind of a sound. You could fail because you either reached for the wrong object or you didn't get close enough to the object. We also gave them knowledge of performance feedback. If people use too much of the trunk to move, which was more than 5 centimeters, that was from our previous studies, allotted amount of movement, we said, okay, no, that's bad. So irrespective if you were success or what, you got a dish. And this meant that the game score, which you saw in the VR, did not increase. We verbally told them the game score in the physical environment. In the virtual environment, they got to see the game score like a thing over here, and some little bit of change in the object became bigger when they were successful and stuff of that sort we did. We also did kinematic outcomes. So we had 25 reaching movements to 2 targets, very similar to what Caroline spoke. So we had people reach to the central lower middle target or to the upper ipsilateral target. And this was either T1 or T3, depending on if your right side or your left side was affected. And these were chosen because you have different combinations of joint movements. Like, for example, in order to reach for the central target, you had to use more shoulder horizontal adduction and more elbow extension, whereas here was less, and you had some sort of shoulder flexion also coming in when you had to go for the targets that were on the top. And using kinematics pretty similar to the OptoTrack bar that Caroline said, we put markers on the body and that actively tracks it. We looked at how fast people were moving, and we also looked at joint ranges of motion, amount of elbow extension, shoulder horizontal adduction, or think about you're slapping somebody, so movement from this way to this way, shoulder flexion, and trunk movement. How much were they moving the trunk? So our original RCT had 32 participants. Only 24 of them, however, completed the neurocognitive scores because some people just didn't want to go. We had to cancel appointments. People got sick, blah, blah, blah. So we ended up with 12 per group, where predominantly there were more males. Side of hemiparesis was reverse kind of. We had four over here and with right side and 8 with left side affected, whereas here was reversed. They were matched in age, time since stroke, and average Fugel-Mayer score. There were no differences between the groups at baseline. The clinical and neurocognitive scores were also pretty well matched. They did not matter. So in short, at baseline, both groups were the same. There was no difference between the two groups. You might see in attention that these scores are slightly higher, but we had so much variability over it that eventually there was no difference. So first, I want to take you through the kinematic scores. So in blue, what you're seeing here is change in the physical environment. And in red, what you're seeing here is the change in the virtual environment. And we did percentage scores. So we wanted to see the amount of change from baseline because it was so variable. So to overcome the variability, one of the things we did was to see what percentage scores. And we found out that for elbow extension, those individuals who trained in the virtual environment actually had greater gains at retention. So which means their motor learned and the learning was there. There was already change here, but this change was retained better. Similarly, for shoulder horizontal adduction, we see that there are some between target changes. Similarly, for shoulder flexion, we see for both the targets it improved. For shoulder horizontal adduction, because you needed more for the lower middle target, that is where you saw more of the change, which was statistically significant. For trunk displacement, we saw the fact that for both the targets, here we have negative change, which is good because people are using less trunk. So people are using less trunk immediately after the training. However, we again see too much variability over here that precluded any change at retention. Speed, we did not see any great change. So both of them actually improved speed to the same extent in both the groups. Now, it's interesting what we did with this cognitive score. So we had all these scores. We wanted to see if we can do any prediction with having deficits in certain cognitive abilities on your capacity to improve. So along with a brilliant statistician at that point of time, we combined data from both the groups because we did not see any change in the neurocognitive patterns at baseline. We combined all that data and we performed a factor analysis. So it's like you put everything in a mega regression soup and you get it out into two different patterns. So we had two factors. This is statistically, you need to have an eigenvalue more than one. And together, this explained about 73% of the variance, which is fantastic. So our first factor actually combined attention and visual perception and visual construction. And the second factor looked at memory and problem solving. In other words, after all the statistical mumbo jumbo, what happened? So improvements in motor performance and the movement patterns were related to attention and visual perception and visual construction and better ability. So if you look over here, if you had fewer deficits, you have negative, and these were moderately correlated, not very strong, but there's moderate correlations. So if you had fewer deficits in attention and memory, you got better shoulder flexion for the lower middle target. Similarly, for the shoulder horizontal adduction, and you had some correlations with speed and with shoulder horizontal adduction and elbow extension. So what does this mean for us? If you train individuals using virtual environments, they lead to better changes immediately after training. And some of these changes were retained compared to similar dosed match training in a physical environment. And our results are suggesting that maybe use of virtual environments may be a better medium to provide feedback, especially KP feedback. The ability to use feedback was influenced by what kind of neurocognitive functioning they had and what kind of deficits they had. So if you have better memory, you have fewer problems and you have better problem solving skills, you have good attention, you have good visual perception and visual construction skills, then these are the folks who are likely to improve better when you provide them with feedback. Thus, we can conclude that the training environment and the levels of cognitive function are associated with our ability to use critical information about the results of the pointing performance to modify movement kinematics. Caroline mentioned about implicit and explicit learning. This learning was implicit. If people use the trunk, we gave them that negative feedback. We did not tell them what was wrong. We only told them they did something wrong. So they had to problem solve effectively and know, why did I go wrong? Did I use my trunk? Did I not get properly? Do I have to get close enough? So we kind of challenged them to a little extent to go to that next extent, figure out what was going wrong, and then being able to do. And people who did better with that were those who succeeded in this sort of a paradigm. So what are the clinical implications? This is my last slide. It is suggested that individuals post-stroke be screened for the presence of cognitive deficits, especially in the chronic phase. You can use either the MOCA, the Montreal Cognitive Assessment, or the Cognistat. And information on the presence of these cognitive deficits can help to select the most appropriate interventions. Because if you're having somebody who's having a lot of cognitive deficits, maybe virtual environments are not the best way to train them. Maybe train them in a physical environment. Maybe, for trunk restraint, if you want to use, just put a trunk strap and then do real world training. Maybe virtual environments are too much for these people to take. Maybe it's not the right thing to do. As Caroline said, this was part of my PhD and postdoc, which I did in Canada in Dr. Mindy Levin's lab. So it was supported by grants from Canada. I want to thank my participants, Dr. Joel Crane and Dr. Maria Ferraccio, who did the neuropsychological assessments. All these wonderful people. I want to thank Professor Homburg, Dr. Nirmal Surya, Dr. Hita Someshwar, and Dr. Maria Alejandra for the invitation. And I want to thank members of my committee, Dr. Mindy Levin, who was my supervisor and mentor for life, Dr. Heidi Sveistrup, and our statistician, Mr. Georg Scholingarian. Thank you so much.
Thank you so much, sir, for that enriching presentation. It's very nice, sir. We have a few questions for you, sir. So the first one is, if the person, did any of the people have perceptual disorders, were they in inclusion or in the exclusion criteria? Like aphasia, if they had any perceptual disorders?
See, I mean, aphasia was, we did not say no to anybody with aphasia because we were not doing anything speech related. So I do remember we had a couple of people with aphasia who did come. And yes, they did have a little more visual perceptual deficits. And as a result, they did have some issues. One of the participants, when they said perceptual, I remember very specifically, I think we had to stop the neurocognitive testing because it was way too much for this participant. So that participant's data was not included eventually. So that was it. We did not have anything specific with that sort yet. If they had neglect, they could not come. Like, we did the line bisection test, as Caroline mentioned, and if they had like really bad neglect, we did not take them because the virtual environment wouldn't be useful to them. Other than that, we didn't have any of the other bigger issues that were really preventing us from doing it. I mean, if they could do it, they can. And the neuropsychologists are very good because these were two people working with stroke patients. So they had their own ways, tips and tricks. I've attended a session with them. I didn't see any of the results, but I attended the whole training, the whole evaluation session to see what they were doing and understand how they could do these things. So they would actually quite adjust their schedules to help these people do the stuff.
All right. So one last question for you.
Yeah.
Thank you for the great presentation. Can I please check that spasticity and pain were considered as contributory factors in these enrolled patients? The Shaddock-Makester stroke assessment measures factors these in for points 3 to 5 as well as on the impairment inventory, and were these factors optimized?
I mean, the point was we didn't have, the truth of the matter was we were not doing the spasticity work because this was prior to the spasticity work that came by. So we did not see anybody complain to us, like in other words, no, we did not specifically optimize these factors. But the way to make sure that it didn't increase is nobody came to us and said, you increase my pain or that I'm more spastic, I'm not able to move. So in a certain sense, by doing the movements, I have anecdotal evidence that people got better. The range of active elbow extension improved. They could move their elbow better. So in a certain sense, you might think that, yes, the TSRT could have improved, like what Caroline mentioned, that the range of active control improved because they were able to use more elbow extension with less trunk movement. So in a certain sense, I would say that is anecdotal evidence, but I cannot say it is what it is because we didn't measure it. So that is the way. And pain was, nobody came and told us that there was too much pain. The one thing I didn't say is if patients were getting tired or if patients were complaining of some discomfort, we actually, the 72 trials that we had, we could break them down into 6 parts of 12 or 4 parts of 18 or 3 parts of 24. However, actually, because this was more of the chronic phase, our patients were like, no, I like it. Come on, let's go. Let's keep going. Let's keep going. And I have to tell them, no, hold on. You cannot train this way. We cannot do this with you. Please wait. It's not possible. So we had to keep reminding them about those things. Sometimes if I did the training, the data came to me because it was a double-blind study and I recorded the kinematics myself. The data then came to be completely, labeled to me. So if it was like, say, patient ABC, that would come to me as 1, 2, 3. So I had no idea if it was pre or it was post. So I was kind of blinded to the actual patient and who it was. I knew the data was there, but I had no idea. And I just knew if it was right side or left side, because when I do my kinematic analysis, I'll know that. But I didn't know which patient this was, who this was, when this assessment was done. And all the analysis was done after a year. So everything was completely blinded. We had a person offsite doing all that.
All right. Thank you for that answer, sir. Maybe if you or Caroline, one of you all can take this question. This was there last time and we just moved on.
Yeah.
Someone asked, for achieving extension, what was the position of the forearm in your study?
For
Was it
achieving,
supine?
like during the training or during the test task?
It's just an open question, so if you can just take both.
I mean, so for the training, the forearm was placed in a horizontal manipulandum the whole time, so the arm was always supported. But then for the test task, it was just it was like a free reach to touch or reach to grasp task, depending on hand impairment.
So when I did the study earlier, what we did was we looked at where the TSRT was. So say, for example, in a better term, like, as physical and occupational therapists or as neurologists, or, when we stretch the arm, we go to see beyond the range, beyond where we start having that first catch or the tightness of the muscle starts, So say, for example, if I'm moving here and I think it's 90 degrees, and I want to make sure that the person can move. So the arm will be set in 40 or 50 degrees so that they can move until 90 degrees without any problem. For me, when I went into the spasticity zone, then I might place the arm in 60 degrees of flexion, and then where full 180 is full extension. And when they moved, they were moving beyond that 90 into this place where they were having more things. So in Caroline's pattern, in Caroline's training paradigm, I know it is similar, that the range was actually more so personalized to where you saw. So say, for example, if the spasticity came later in the range, only at 120 degrees, so maybe then they can start at maybe say 80 or 90. But if the spasticity came earlier, then you have to go closer over here. And then because you only have that small range to move. The idea is that spasticity should not preclude movement. If you have this range where the muscle activation is good, you don't have excess co-activation, you don't have the problem of too much antagonist activation, work in that range, because your brain remembers movements. Your brain does not remember actual patterns. It doesn't remember muscles. It's muscle memory we talk about, but you need to move. So even if there's such a small range for you to be able to move, let's get moving over there. And the idea, what they did is, if we are telling the brain that, hey, you're actually able to do this, so it's something like the virtual training where we are fooling the brain to say that you're moving more than that. Oh, I can do it. It's good. And I'm not stopping myself. So we are having those plasticity mechanisms come up and help us.
Okay, thank you. One last question before we end this webinar is maybe two, maybe. So the last one is, what way does the command play its role in the outcome of VR versus real life activity training?
That's a really good question. And I think the way to answer this would be that the studies that Caroline and I have done previously, the issue is there a problem with the motor command itself that is coming, or is there an execution problem? In other words, if you guys are riding a bicycle, okay, and you tell me I can't ride a bicycle, is it because you never learned how to read it? Or do you have problem in your knee, like knee pain, that is preventing you from doing it? If you have knee pain, you take medication, your pain is gone, you can do it. So the problem, I think, Kathleen, I'm not speaking for you, maybe you can do, but I think even your participants did not have the problem in moving too much. So the motor plan seems to be okay, but the execution of the plan, so everybody's learned how to ride a bike. The fact, and there are some stroke patients who won't be able to do, motor planning will be affected in some patients, I'm not saying no. But the patients that we recruit, given the fact that we have all these inclusion-exclusion criteria, what we see is that these people can actually do it, but the execution of the plan becomes a problem. How the visual environment is actually impacting that plan, that's a good question. But we are able to see good transfer, because in my study that I presented, the kinematics, we did the training in the real environment only. You would think you're training in the physical environment, people will get better, but we actually saw that the virtual environment led to greater gains for us. So people were able to not to transfer that, and that kind of helped some of these abilities to transfer. Caroline, you found something similar, right?
Yeah, like we have people transferring the like better endpoint performance, for example, from the training to a test task, but also to comment on like the actual execution of the motor command for my training, for example, like we are specifically calibrating the training so that it's only in a zone where patients have full control over their movements. It's not affected by spasticity. So we're limiting the actual area based on the elbow flexor TSRT. So they're not, the training won't tell them to move beyond a certain angle of elbow extension. And also in the case, like this just comes up like anecdotally, if like patients come and they have spasticity in both elbow flexors and elbow extensors, we're able to kind of take a smaller area, but still work with that.
There was one more question, Hitao. I think the question disappeared.
Yes, a second, just check. That was just a comment, sir, which says because Sinaji Patin will dominate and against pattern to get movement is really challenging.
I mean,
That was just
that's completely, I agree with it, which is why we went specifically for that. We went to this lower middle target because we wanted people to break that anti-pattern movements, and which is why we saw these changes. So when we seeing these changes, we actually did see. But funnily enough, when Dr. Kim was practicing, when you looked at those meta-analyses, my study was the one which had the negative effects. Our Fugel-Mayer did not change as much. So it's kind of funny that we are showing kinematically people are getting better, but in Fugel-Mayer they don't seem to improve. Again, that might be due to the thresholding effect, and people in both groups are improving. So when you look at those kinds of clinical measures, yeah, you did the task better, but how did you do it better? It comes from this. And I do agree that it's difficult, for clinicians to be using movement motion analysis and all this in the labs. But we do have reaching performance scale and this index of performance, and the other clinically available scales are available for free that you can use. So you have some idea about how the patient is doing. Because it's not just enough for us to say you're improving, but we have to pay more attention to the pattern and how they're improving, and that's what helps us get better.
I've got one last question. It's just an open question. We've seen everyone talk about virtual reality and upper limb, but virtual reality and lower limb not touched or not needed, or how is it?
There's a lot of evidence in that too. It's just that
I know that's right, but
no, we all love the upper limb. That's the only reason why. So we are kind of weird because Sulfi and I, Caroline, correct me, but you don't have a PT background, right? Or do you?
I'm in neuroscience. I'm not a PT.
Okay, you're in neuroscience. Okay, so Sulfi and I are both kind of, we're like weird PTs because we like the upper limb. And I know Sulfi, I've met him a couple of times. So yeah. I mean, there is sort of beautiful evidence. There's many good meta-analyses that have been done for the lower extremity as well. And VR works. I mean, for gait training especially, it's fantastic. It actually helps. The thing that comes is that with the lower extremity, your training has got to be more specialized with certain things. You cannot just play a game like a Wii or, something of that sort, and you cannot get people walking better. You might get the V balance board for postural control. You might be able to play some of those games and you can do that. But if you want to change walking, then it has to be those really expensive kind of paradigms, which is why applying that, in an Indian context or in a context of for any other developing country, that might be a little bit of an issue, because you need the specificity, you need to have the big institutions that can actually do it for you. Whereas the upper extremity, I think it's easier for us to apply because we can use cheaper games to do it.
Recently, there were these treadmills which had incorporated virtual reality in them with projector based this thing. But again, let's say we get more evidence from the developing world and cost effective machines. So let's see. There is someone who's asked, VR gives restricted environment compared to physical training.
Disagree on that point. Not completely. I mean, I see where they come from, but the point is how you want to develop. I mean, I was very lucky to get into an environment, and Caroline is in the same environment as me where I train. We've had a lot. We've got good money. We've got good engineers. We've got good people to help us train. And I'm now also a consultant to a company on a project where I'm trying to tell them how this can be improved so that we can give it in the house to the people. So the technology is catching up. It's going to take some time. I mean, the first time I went to the ISVR meeting was way back in 2006, where we were pretty happy if people were publishing results with 5 participants. Now we are talking at a level where we are saying that we want to do meta-analyses, we want to do this, we want to see what kind of publications are coming through, what's happening. The field is changing, and now we are really talking to the engineers, and we are telling them, guys, you're doing great, but get me more of this, get me more of that. I mean, this is what we need. And this is where I think fora like this were pretty useful, because we need to have people tell us. I consider myself a clinician researcher. I don't do development, but I talk to developers. So if we know what are your requirements, what do you need, you do it, which is why I like Sulfi's game when he had the making the dosa. That will only come in India, like nobody else. You might call that making a pancake somewhere in the West, but that's so Indian. That's something we do. Washing clothes, that's something we will do in developing countries and, in Asia and maybe Africa, but you will not do that in the European or the American context, because nobody actually does the kind of clothes washing we do. So the contextual factors are also very important. We have to develop that. And, that is where we need a suite of games available for us, that we can change them according to what the needs are. Point is, the movement has to happen. Now, how you make that happen, what game you want to choose is your choice. It can never replace reality. That's true. But it's always an adjunct. It's something that helps us do better, makes it more motivating, makes it fun, makes it more challenging. That's what I like.
All right. Thank you everyone. Caroline, Zulfika, Sandeep sir, Maria. And just before we close for today, I'd just like to bring to your notice that today the last day to submit your abstracts for the 13th World Congress on Neurorehabilitation, which is going to happen in Canada in 2024 from the 22nd to the 25th of May. Please be there. This is a formal invitation from everyone working for WFNR. And again, the World Federation of Neuro Rehab has 2 travel fellowships for students, young WFNR members, and young neuro rehab specialists. So please put in your abstracts and write to Tracy Bol on the WFNR email to be able to get this $1,000 travel fellowship for the 13th World Congress on Neurorehabilitation. Thank you, and we would like to hear from you. And please be part of the Young WFNR. The email address is put in the chat box by Kristen. And we hope to see you all really soon. Whatever day it is, have a good day, good night, have a good evening. Thank you. And Maria, last few words from you, please.
Thank you all for your participation. We thank to all the speakers, excellent presentations, and especially thank to Tracy, Christian, and Hitap. We hope to see you in the next webinar. Bye.
Thank you. See you. Bye-bye.
Thank you. Thank you.